dear colleagues. Here are my financial disclosures. None of them is relevant to the topic of this talk. And after very elegant introduction on epidemiology, I would like to show just one slide. It's an estimate published in Ophthalmology last year showing what can happen in the nearest future or in the future, showing that we face not only epidemic now, but it will increase in future, and it shows the increase in global prevalence of myopia and in high myopia parallel to low or general myopia, which is of major concern to us here. Let me start with the meta-analysis, which was published last year in Ophthalmology Journal, which compared 16 interventions for myopia control in children. And this study shown that only atropine in different concentrations, 1% to very low dose atropine concentration, 0.01%, shown clear effect in myopia control, all of these different concentrations with statistically significant effect. Then another group included moderate effects, and there were within this group pyrazipine, autokeratology, and peripheral defocus modifying contact lenses. Then they also pointed ineffective approaches, all with no statistically significant effect, and included to this group rigid gas-permeable contact lenses, soft contact lenses, under-corrected single-vision spectacle lenses. I highlighted it since in many countries it is still used practice to under-correct spectacles and timolol. So coming from this meta-analysis, we are quite aware that options for the active management of myopia progression include pyrazipine, atropine in different concentrations, soft contact lenses with myopia control features, and also keratology. Also, all of these different approaches might have some limitations, like side effects concerning atropine 1%, cost and complexity concerning also keratology, and availability concerning pyrazipine. What do we know about each of these strategies? Pyrazipine was studied in different interesting studies, double-mask, placebo-controlled studies in US and in Asia, and it was shown that it provides myopia control with less light sensitivity and fewer near vision problems than 1% atropine. However, long-term use has not been proven to be effective, and pyrazipine is not commercially available. Atropine has been used in myopia control for a long time. The first reports come from the middle of 19th century. However, the first randomized placebo-controlled double-mask study comes from Singapore, from Donald Tan group, and it was published in Ophthalmology 2006. It is known as an ATOM-1 study, and in this study the group shown that 1% atropine was able to slow myopia control regarded as a spherical equivalent change, what is shown here in 2 years, and also regarded as a mean axial length change as it is shown here. However, after this study, it was quite obvious that 1% atropine is related to significant side effects, including photophobia, decreased visual acuity, abnormalities of accommodation, and problems with near vision, which might significantly limit its usefulness. So there was another study called ATOM-2 study by the same group, published in Ophthalmology 2011, which compared different concentrations of atropine low doses 0.5%, 0.1%, and 0.01%. And this study proved that all of these concentrations were still effective, as we can see here, compared to placebo. This was a spherical equivalent here, and also regarding axial length, the same. All of these concentrations were still quite effective. And regarding side effects, this is the table from our study from 2015, which shows here bolded numbers that in the lowest concentration of atropine, 0.01%, this lowest concentration affects pupil size only slightly and does not really affect accommodation amplitude comparing to other concentration of atropine as it is shown in other columns here. Recently, last year, the same group published 5-year results of using the lowest dosage of atropine, 0.01%, and they shown that after 5-year use, they achieved, they were able to show to slow myopia progression by 50% here. They also argued in conclusions of this study that daily dose of atropine, 0.01%, is an effective first-line treatment in children aged 6 to 12 years with documented myopic progression of half a diopter in the preceding year with few side effects. And because atropine appeared more effective in the second year than the first, treatment initially should be continued for at least 2 years. There are only a few studies on non-Asian populations. This is one of this study from Europe, very interesting, published last year in Eye. This was based on atropine 0.5%, so not as diluted as this lowest concentration. And in this study, it was conducted in Rotterdam, in Netherlands. The authors were able to show the effectiveness of this atropine, as you can see on this graph here, during the 12-month period. However, they also noted quite significant rate of side effects. 60 to 70% of patients reported photophobia, and about 30–40% of patients reported reading problems. There is one more substance I would like to mention. This is 7-methylxanthine. It's a non-selective adenosine antagonist, and this substance was shown to prevent experimental myopia in different animal models, including guinea pig, rabbit, chicken, and rhesus monkey. And there were some studies on humans conducted in Denmark by Klaus Trier, who shown that this substance, methylxanthine, used in the dosage of 400 milligrams twice per day, reduced myopia progression and excess eye elongation by around 50% in children aged 9 to 13 years. And these authors were also able to show that the treatment of 800 myopic children, adolescents, for a period between half a year to 8 years was safe and without side effects. And they also reported no rebound effect after stopping treatment. What do we know about the role of time outdoors? Just, it's not a topic of this talk, but just to mention, this is a very important issue. That we are quite aware that increased time outdoors prevents the onset of myopia. This is very important what comes from many studies. We are quite aware that increased time outdoors reduces the effects of large amounts of near work and parental myopia. However, the effect of time outdoors on the progression is much more controversial. So, coming to a conclusion, the management of myopia progression today might be based on the low-dose atropine, 0.01%, soft contact lenses with myopia control features, and orthokeratology. There are many questions which need to be answered. Some of them include the additive effect of combining atropine with other emerging myopia therapies like contact lenses and environmental interventions like increased outdoor time. Finally, we have many questions regarding clinical treatment algorithms. Which children would be best benefited from treatment in terms of age, level of myopia, rate of progression, and family risk factors? When atropine should be started and stopped, and for how long it should be used. All of these questions should be answered in further studies. And I would like to thank all my collaborators, Dr. Iriberin from Argentine, Professor Ian Morgan, and Klaus Thier from Denmark. Thank you very much for your kind attention.
Thank you, Andrzej. Is there any question or comment from the audience? Yes, please.
This is Sharif Sheta from Egypt. In Egypt also we have a problem of high myopia. And I'm wondering if there is any surgical attempts to decrease this progression of myopia. There have been reports about scleral reinforcement. We tried to do scleral cross-linking to increase the rigidity of the sclera without much success. And I'm wondering if there is any role for surgery in prevention of progression of myopia.
Yeah, thank you very much for this comment, but it regards the surgical, let's say, approach. Yeah, thank you.
Yes, please.
I'm Dr. Kumar from India. How would you prepare atropine 0.01%? Do we use the injectable ampule and prepare the drops? And the second question is, in your own practice, since you have found that it works well, what are the groups of children in whom you have been prescribing?
Yeah, thank you for this question. So I'm not preparing atropine by myself, I must say. I just prescribe it and the patient go to the pharmacy. And at least in Europe, we do not have any ready-to-use medicine. So it is just prepared as a compounded pharmaceutical by the pharmacy. And some pharmacies can prepare it better and some worse. This is one of the problems. When we can see some adverse effects when the patient complains of photophobia or problems with reading, we might suspect that it was not diluted appropriately. So this is one of the points. Then in which group of children I'm using? I'm using it in quick progressors. When I see a kid progressing 1 diopter per year, I'm usually especially with some risk factors like parental myopia, I'm usually proposing, this is obviously off-label therapy, proposing parents to consider this form of treatment. They give additional consent for this treatment, and we started.
Okay, thank you, Andrzej. Let's move on. The next speaker will be Kyoko Onomatsu.